Hello everyone and welcome to Face and Neck Injuries. This particular lecture is actually pretty in-depth. The face and neck house some significant structures to everyday life, and we want to make sure that we have a really pretty good understanding of what's going on. And as you can see just in the title slide here, an eye injury just like this can look particularly gruesome. So I want to make sure that we're rolling through this and understanding exactly what it is that we're trying to treat and what the major impacts of certain injuries are. So as the introduction says, the face and neck are pretty vulnerable to injury. It's relatively unprotected, and the soft tissues and fractions that are common can vary in severity, and something that may seem potentially minor could actually negatively affect a very important structure in the face, that being of the eyes or something like that, or even in the neck, where we can injure something and compromise an airway. So some injuries can be potentially life-threatening, and that's penetrating trauma to the neck, which may cause severe bleeding. Remember, we have two very large arteries running up into the brain, and then an open injury can result in an air embolism or something of that nature. Face and head are the primary means of getting air into the body through the mouth and the nasal passages, and so this can compromise just the simple ABCs of your patient assessment with somebody with significant injuries. Continuing on with the introduction, the appropriate pre-hospital and hospital care. Patients who seemingly have devastating injuries can actually have good outcomes, and this really comes back to the protection of the airway, maintaining somebody's ability to breathe, and helping to create that perfusion status. And then we want to make sure that when we're dealing with objectives on patients with face and neck injuries, we want to prevent any further injury. We want to manage that airway as best we can and control the bleeding to the best of our ability. So as we're talking about the anatomy and physiology of the bones in the head, we're talking about the cranium. This is referred to as the skull. It is the cranial vault, or it contains the brain. The most posterior portion of the skull is called the occiput, and the lateral portions are called the temples, or the temporal regions. Between the temporal regions and the occiput, and this is kind of up at the very top of the skull, in between the base and the temples, is called the parietal regions. The forehead is the frontal region, and if you're palpating on the scalp anterior to the ear in the temporal region, you can actually feel a pulse of the superficial temporal artery. It's actually fairly easy to locate, and you may have already found it just in perhaps light massaging the temporal area, like during, say, a headache or something of the like. So the face is comprised of 6 major bony areas, and this includes the nasal bone, the 2 maxilla, which is the upper jaw bones, the 2 zygomas, which is the cheekbones, and then the mandible, which is the lower jaw. This is the part that's actually articulating or hinged and facilitates in chewing. In regards to the orbit of the eye, this is composed of the lower edge of the frontal bone, which again is the forehead, the zygoma, and the maxilla, and the nasal bone, and these structures protect the eye from injury. There's actually a fairly deep recessed pocket in these bones, allowing the eye to sit in that structure with some small thin muscles that surround the actual eye. And then there are 2 penetrations into the cranial vault for the optic nerves, both left and right. So in regards to the nose, everybody should understand that the proximal third of the nose, which is the area closest to the actual skull, is the only part that's actually formed by bone. The rest of the nose is actually composed of cartilage. It's flexible and not very hardened, and the mandible forms the jaw or the chin. And remember that the mandible is the hinged portion of the skull that allows chewing to happen. This motion occurs at the temporal mandibular joint. As we've talked about in previous lectures, the neck contains many important structures with very large vasculature into and out of the brain, the airway, as well as a lot of muscles that are controlling and stabilizing the skull, along with the cervical spine. The upper part of the esophagus and the trachea are midline in the neck. The carotid arteries are found on either side of the trachea, along with the jugular veins, with obviously the jugular veins being more superficial than the carotid arteries. And in this diagram, we can actually see some more of the anatomy, primarily that being composed of the muscle that's around the neck coming into the traps. You can see the sternocleidomastoid, which is the primary flexor of the neck, which will allow the head to move forward and some of the side-to-side twisting motion. And then as you're looking a little bit deeper, you can see the carotid arteries, also right next to that with some internal jugulars. And then as you're looking into the middle, you see that what we call the Adam's apple, which is a thyroid cartilage with the cricothyroid membrane and the cricoid cartilage. This all creates that structure as it goes into the trachea, which is then going to branch into the bronchioles. We're going to look a little bit closer at that structure that we call the Adam's apple, and this is the cricothyroid membrane, which is between the thyroid cartilage and the cricoid cartilage. If you're looking at that, that's just a very small membrane in between those two portions, and it joins the two cartilages together. The trachea connects the oropharynx and the larynx with the main passages of the lungs. So remember that trachea comes down, it splits into the two bronchi, which then turn into bronchioles, which further split, again, kind of like that fractal pattern, all the way down into the alveolar pockets. The carotid arteries are easily palpable. And if you guys remember, if we have a carotid pulse, we generally assume that that patient has a blood pressure of somewhere at least around 60. And internal jugular veins and important nerves are going to sit next to the carotid arteries, but you can't actually palpate them because there's no pulse pressure for that vein. Again, that sternocleidomastoid muscle, it originates from the mastoid process to the cranium, and it is the primary flexor of the head and neck. And then to the posterior of the neck, we have the spine of the cervical vertebrae. The most prominent one, the one that you can actually feel pretty typically as it runs into the shoulders, is the 7th cervical vertebra. When we're talking about the eye, it's kind of globe-shaped. It's actually not perfectly round. It's a little more oblong, and it's about 1 inch in diameter. It's located in that bony socket, and that's called the orbit. More than 80% of the eyeball is inside that particular orbit. And again, if you were to see it like removed from the skull, it's not that perfect sphere that you would typically think that it would be. And so as we're looking at that particular kind of cross-sectional view diagram of the eye, you can see the many different functions and portions of the eye that create vision, that being optic nerves, arteries, and veins that run actually into the cranial vault. You can see the actual lens, the pupil, the cornea, and the iris. And the eye is actually a fairly complex organ. Getting a little deeper into the anatomy and physiology of the eye is actually filled with a clear jelly-like fluid near the back of the eye, and that is called the vitreous humor. A little unknown fact for a lot of people is that if you have what we call floaters, or things that you can see in your vision when you're not actually concentrating on something, that's actually that jelly kind of hardening up. It's small flecks of it that are just kind of suspended in the jelly of the eye that you can actually see on the retina. In front of the lens of the eye, it's called the aqueous humor. This can leak out in penetrating injuries, and with time and treatment, the body will typically make more, so long as that eye injury is actually closed. All right, so as we're looking at this picture, you can see the lacrimal glands, which are the tear glands, and that's in the upper eye. You can see the diagram of the pupil and the iris, and then eventually you can see the nasolacrimal duct, which allows tears to drain into the nasal passage. The sclera is the white of the eye. It's pretty tough, fibrous tissue that maintains the eye shape. The cornea replaces the sclera on the front of the eye. It's clear, transparent. It allows the light to enter the eye. The iris is the circular muscle behind the cornea. The pupil is the opening at the center of the iris. This allows light to move to the back of the eye. And in one of those oddities, when you're doing your normal assessment on patients, you may run into a couple of people every once in a while that have a condition called anisocoria, which is a condition in which the person is actually born with different sized pupils. So when we're talking about that equal and reactive to light, make sure that if you have a patient who's alert and oriented and you're evaluating them for that and you see an uneven pupil, ask them if that's a normal physiologic sign that they've always had and they were born with it. Some patients may have had a traumatic injury to that eye, which would also cause something very similar to that. You don't want to be confused with a TBI on something that's fairly normal for that patient. Now, the lens actually sits behind the iris, and the lens is what actually focuses images of light onto the back of the eye, which is called the retina. And the retina contains the nerve endings that transmit nerve impulses through the optic nerve to the brain. And the optic nerves actually cross over each other, so the left eye feeds the right side of the brain, and the right eye feeds the left side of the brain for its actual impulses. The retina is nourished by blood vessels that are called choroid, and a retinal detachment will actually cause blindness, and in most cases it can actually end up being permanent blindness. Okay, moving on to a different structure, we're going to talk about the ear. The ear is a complex organ associated with hearing and balance. The exposed portion is made entirely of cartilage and it's covered by skin. The pinna is the external visible part of the ear. So that's anything external of the head. And then the earlobes are the fleshy portions at the bottom of the ear, which are either attached or detached, depending on genetics. The tragus is the small kind of round bump that's directly in front of the ear canal. In regards to how the ears help perform balance, there is some fluid in the inner ear that is actually used for equilibrium. And one of the things that some patients may experience is called vertigo, where small crystals will actually form into that fluid. And as they're moving around inside the inner ear, that patient will experience what they consider to feel like movement, even though they're in a fixed position. A little bit more on that ear. The middle ear contains 3 small bones, the malleus, the incus, and the stapes. It moves in response to sound waves. The ear is actually connected to the nasal cavity by the eustachian tube, and this is where small children that have poor function of this will actually develop these ear infections because they're not actually draining into the sinuses. I'm not going to get too deep into this diagram. This is probably a little bit more appropriate for you guys to kind of go through in your book, but you can see that there's some significant and complex structures inside the inner ear, and that's where all the magic is happening in regards to somebody's sound or perception of sound, and again, how this works in conjunction with the balance. So it goes without saying that injuries to the face and the neck can lead to an obstruction of the upper airway, and this is something that we really want to make sure that we understand. If we have really heavy clots that are draining into the airway, this can form heavy clots. Direct injuries to the mouth and the nose and the larynx and the trachea can cause tissue swelling, and it's going to actually occlude that particular lumen. And we want to make sure that we're trying to be very mindful of these structures and how delicate this can actually be in regards to whether or not we can place a supraglottic airway or things of that nature, and how we're going to maintain an airway, because we're limited as AEMTs on our ability to manage significant airways. Anybody with heavy facial trauma is no longer a candidate for even an NPA. So, and try to remember that anytime that there's significant trauma to the mouth, we can have dislodgement of teeth or dentures or pieces of bone or other things like that that are actually in the back of the throat, which could become a potential blockage in the airway as well. So one of the things that we're going to talk about is soft tissue injuries in the face and the neck. And if any of you have seen somebody with a facial injury, you know that the head and neck are extremely vascular, and they tend to bleed profusely. These patients will look like they are just losing copious amounts of blood, and you know, any more than 10 or 15 cc's looks like a lake, and it's really hard for us to identify just how much bleeding has actually occurred. We're actually pretty terrible about it in the field. And try to remember that swelling is going to happen on this smaller tissue, and it's going to become very prominent very quickly. So when you're dealing with head, neck, face injuries, you want to make sure that you're stopping any bleeds that you can, you're maintaining airways, and you know, you're doing the best that you can to get your patient kind of assessed and treated as appropriate, and then getting them to the right place. In regards to significant facial trauma, facial fractures can happen when the facial bones absorb a really strong impact. The magnitude of force required to fracture the maxilla can produce closed head injuries and cervical spine injuries, and this is that high index of suspicion, right? So if somebody takes something like, say, a steering wheel to the face, they're a real likely candidate to have a cervical spine injury. This is much less than, say, somebody getting stabbed with an ice pick in the neck or something like that. That's a low likelihood or a low mechanism for cervical spine injuries, unless that actually impacted the cervical spine. And we want to make sure that regardless of the injury, if it's the head or the neck, and we're just suspecting that there's something going on that could have damaged the CNS or the peripheral nervous system, we want to take that into consideration. We want to have these people in C-collars, and we're still absolutely focused on maintaining an appropriate airway. Now, signs and symptoms of facial injuries, obviously, if we have really deep lacerations, we know that they took a significant blow by something that was sharp. If there's pain over a bone and there's any kind of like crepitus or movement with palpation, we know that that's a significant factor in whether or not that was fractured. And then if there's that ecchymosis, right, the discoloration and the swelling, that could be something that's fairly benign with just a small injury in the right place, or it could indicate that it took enough force to actually do that. Obviously, if you have a misalignment of the teeth, or there's a significant deformity or asymmetry or instability of the bones, we know that we have really pretty big problems. And if we had any kind of impaired ocular movement, right, like if the eyes are unable to look to the right or something like that, or we have some visual disturbance because there's a lot of swelling and pressure being placed on the eye, those are all cues that we have something going on around the orbit. Nasal fractures are the most common facial fracture, and that's usually the cartilage being separated from the nasal bone. This is often accompanied with swelling, tenderness, and crepitus, and it can be complicated by nosebleeds, which can compromise the airway. If you guys remember, we were talking about bleeds earlier in a previous lecture. One of the things that we always want to make sure is if somebody has a significant nosebleed, that we're trying to make sure that that patient is not sucking the clot back and causing more bleeding. And unfortunately, with somebody who has a nasal fracture, they're very unlikely to let you pinch their nose. So you're just going to kind of have to try to deal with this, and you may pinch the very ends of the nares if they'll allow you to, so that the sinus passages can fill up with blood, coagulate, and kind of block off and stop the bleed. Anybody with a mandibular fracture had some kind of resultant blunt force trauma to the lower third of the face. This is usually some kind of assault. It may be a car crash where somebody connects with the steering wheel, and the jaw may be actually fractured more than one place. This usually shows up with a misalignment of teeth, numbness in the chin, and the inability to open the mouth. And the numbness of the chin is because of the actual nerve that runs through the lower jaw. This is the same nerve that if you go in to go have, say, dental work done, that they're injecting lidocaine into. The maxillary fractures also take a significant amount of blunt trauma. They include a lot of facial swelling. They have the instability of the midfacial bones, right? So the nasal bones and the zygomas are probably going to have some instability. The teeth are going to be misaligned, and the patient's face may actually appear elongated. And we're going to get into the Lefort fractures here pretty shortly, and you'll see where these fractures are actually coming from and how we classify them. As promised, we have that midfacial fracture, and if you're looking at the portion with the lowest red line, right, this is just over the maxilla, this is a Lefort 1. And then we get up into where the orbits are, that's a Lefort 2. And then when we get into the upper parts of the orbits all the way across the face, that's a Lefort 3. And as those fractures and dislocations become evident, you will actually see the face will tend to droop down, because now the muscle and the skin is the only thing keeping the structure in some kind of proportion, and they get a very different look to their face. So this is a cutaway portion of where the orbits are going to be, where the eyes are, and then the actual cranial structure between the sinus cavity and the lower part of the orbit. These can cause a couple of different symptoms, one of them being double vision, and this is because of the pressure or the swelling pushing up against the eye or changing the actual curvature of the actual globe, which would cause the visual image to not actually converge on the retina in the right place. And so at that point, we get that kind of double vision. They may lose some sensation above the eyebrow because of the nerve that runs through the face there. Then we're going to talk about zygomatic or the cheekbone fractures. This is usually from some kind of blunt trauma. This could be somebody who was in some kind of assault or was struck with a pretty significant object. This patient will tend to lose that peakiness of the cheekbones, and so the side of the face tends to look pretty flat because the actual cheekbone is going to set a little bit lower. They will lose some sensation over the cheek, the nose, and the upper lip, and more often than not, they're going to have no ability to actually look upwards. Dental injuries, obviously, I mean, this can come from fractured teeth to avulsed, and this is usually pretty typical in a lot of significant face trauma. Obviously, we're looking for mechanism of injury, and anything that has a significant facial injury, we want to know, are these patients motor vehicle accidents, was it sports, falls, or some kind of penetrating or blunt trauma, and whether or not this had something to do with violence or not. Again, anytime you're dealing with something that has trauma, you should have at least a little bit of suspicion that there was some kind of violence involved in this, and make sure that you're prepared accordingly. Always, in the event of a patient with a significant face or head injury or neck injury, we want to make sure that first things first, if we have a significant bleed, we're at least putting pressure on the bleed. If it's at the neck, we're absolutely only putting pressure on the one side of the neck because we need blood flow on the other side of the brain. And then from that point forward, we're really trying to concentrate on maintaining an open and patent airway. If they cannot maintain it themselves, you're going to have to find a way to do it. And if they're not breathing adequately, you're going to have to ventilate for them. If the patient is unresponsive, you're going to have to figure out whether or not they're a candidate based on the actual damage to the head and the face, if they can take a supraglottic airway. That's as far as we can go. If we have anything else that's even more compromised, or we need something else, we need an ALS intercept. Teeth need to be suctioned out of the mouth. We want to make sure that there's nothing that's jagged there to tear any of the cuffs if we are going to use a supraglottic airway, or we don't want it to create some kind of actual occlusion to the actual airway. Palpate the chest wall, make sure that if they had enough damage to their face, that they haven't taken enough damage to their chest, and we're listening for breath sounds in all fields. Suction early, suction often. Make sure that you're getting the airway cleared. If they're continuing to bleed, you need to stay up with that. Again, that early paramedic backup or rapid transport if the appropriate facility is closer than your backup. In regards to your secondary assessment, you're going to evaluate the eyes starting with the outer aspect and work towards the pupils. You're looking for discoloration of the sclera, right? Do we see any capillary bleeds into the actual white of the eye? Ask them about their clarity of vision. Is there symmetry to the pupils? If they're not, you want to ask them if that's a genetic or a result of an injury, or if this is new to them today. If they have a brain injury or nerve disease, that may cause some of the unequal pupils. But again, these people typically know that they have this problem, and if they're alert and oriented enough to answer it for you, they should be able to give you the information. If they can't answer it and you see it, you should treat it as a TBI, which is affecting the optic nerve on that side. We're going to come around to that horse again, right? So you have to treat soft tissue injuries to the face and the neck the same way you're going to treat soft tissue injuries somewhere else. We're always looking for ABCs. We're going to make sure that if we have significant bleeds, that we're making sure that that's stopped if at all possible, and then we're maintaining an open and patent airway and a normal respiratory pattern to keep them oxygenated. Anybody that has some kind of neck or suspected cervical spine injuries, we want to put them in a C-collar so long as we can maintain their airway. Make sure that you guys are using direct pressure when you're trying to deal with a facial bleed. Obviously you can't put a tourniquet on the neck, and so we're going to do everything that we can to use direct pressure with a gloved hand, and we're going to use significant dressings and bandages to kind of help that along. Do not apply a bunch of excessive pressure if you have a skull fracture. We don't actually want to put any more pressure or create the potential to harm the brain if something is loose or fragmented in the actual cranial cavity.